Hello, and welcome to the Clinics Review Articles podcast. I'm Jessica McCool, the Managing Editor for Otolaryngologic Clinics here at Elsevier. Otolaryngologic Clinics is a bi-monthly publication consisting of clinical review articles centered on a central topic. Today, we will be discussing the April 2017 issue on sinonasal and ventral skull-base malignancies. Here now is Consulting Editor Dr. Sujana Chandrasekhar to lead the discussion with issue guest editor Dr. Jean Anderson Eloy.
This is Sujana Chandrasekhar, consulting editor of the Otolaryngologic Clinics of North America, and today I'm speaking with Dr. Jean Anderson Eloy, who is professor and vice chairman in the Department of Otolaryngology, Head and Neck Surgery, and director of Rhinology and Sinus Surgery, as well as Otolaryngology Research, co-director of the Endoscopic Skull-Base Surgery Program, and professor of neurological surgery as well as ophthalmology and visual science in the Neurological Institute of New Jersey at Rutgers, New Jersey Medical School. I'm very happy to have Anderson on with me today.
Thank you.
Today we're going to be talking about the April 2017 edition of the Otolaryngologic Clinics of North America, and this is entitled Sinonasal and Ventral Skull-Base Malignancies. Dr. Eloy is a guest editor of this edition, and he guest edited it with Drs. Michael Setson and Drs. James Liu. Let's briefly cover some facts about sinonasal and ventral skull-base malignancies. They encompass about 0.83 per 100,000 in the population per year. They encompass about 3% of all head and neck cancers. Their presentation is extremely vague, so they often present quite late. There are over 40 tumor types of cancer in this area. The anatomy is particularly difficult. And so this edition looks at sinonasal and ventral skull-base malignancies from evaluation to different types of management, to building a team to manage these well. Dr. Eloy, can you talk a bit about the other guest editors of this clinics?
Yes, my two co-editors are Dr. Michael Setson. Dr. Setson is a close friend and a mentor who I've had the opportunity to collaborate with over the past, I'll say, 10 years. And the other one is Dr. James Liu, who's the director of skull-base surgery and associate professor of neurosurgery at Rutgers, New Jersey Medical School. Dr. James Liu is a colleague with whom I performed all of the advanced endoscopic skull-base surgeries.
Terrific. So this type of tumor is located in a very difficult place and quite rare. What do you think the readership is for this edition of clinics?
So briefly, I do believe that this is a very important issue in the clinic. I think this is something that can be very useful to otolaryngologists that are in training and out in practice, neurosurgeons, ophthalmologists, also radiation oncologists and medical oncologists who treat these patients. I also believe that, as I mentioned, that the nursing staff, physician assistant, pharmacists and technicians that are taking care of this patient can benefit from reading this issue.
What I found very nice in this issue was the accompanying video content that's available on the website. Because the anatomy is so complicated, it is very nice to see some of the approaches illustrated for us with the video when you go on ototheclinics.com to look at that information. So these patients, as we mentioned earlier, can present with really vague symptoms. How does a general otolaryngologist identify these patients, and then what steps are taken to evaluate the tumor and the extent of it?
So typically those patients present with vague symptoms such as nasal obstruction or nasal drainage, as well as epistaxis, which is bleeding from the nose. When they are seen by a general otolaryngologist, the initial step is to perform a fuller physical examination to make sure that you're not missing anything in the exam. And then following that, doing a nasal endoscopy. In most of those cases, you will be able to see a lesion, a mass in the nasal cavity. Once they've noted that, the next step would be to obtain the proper imaging techniques. For those tumors, getting a CAT scan and an MRI is usually complementary. And in some cases, you might need to get a CT angiography, and if once you've made a diagnosis, get a PET scan. However, to arrive at a final diagnosis, typically tissue from the lesion is required to biopsies, and after that, we can start talking about what is the best option. But the evaluation should involve all of those things that I've just mentioned before.
I think a take-home lesson, it sounds to me, when we are examining the nose, is we should make sure we look up as well as in the back of the nose. And I wonder if you might tell me why I shouldn't just biopsy a lesion that I see that's maybe emanating from the maxillary sinus or up near the cribriform plate.
Okay, so there's a few reasons why you would not want to do such thing. The first, you mentioned before that there could be a significant amount of different pathologies that are present in the nose and in that area. Some of those can be very vascular and can have significant bleeding if in an office setting you cut into the tumor. So that's why I would not advise someone to just go ahead and quickly take a piece of a lesion, because you might find yourself in a difficult situation, and it may not be the best options for the patients. So you can create a difficult situation. Also, as you mentioned, if this tumor seems as though it's near the cribriform and anterior ventral skull base, you have to be concerned about creating a defect in the skull base that can give you a CSF leak. CSF again being the fluid around the brain, and that could be something that can lead to a patient having meningitis. So you should, once you see this tumor, you should probably go ahead getting the proper imaging, and then plan on doing the biopsy in a control setting. I prefer to do those in the operating room. In case I run into trouble, I have the proper support staff to help me control any possible bleeding.
Thank you. When you establish that there's a tumor and you've obtained the proper imaging and you've biopsied it, are there particular staging systems that are used to help guide treatment for these patients?
Yes, definitely. There's a few staging system out there that helps. The current American Joint Committee on Cancer TNM staging is the one that is most commonly used. But because there are so many different pathologies in this area, this staging system is not adequate for all of them. As a result, there's been some other staging systems that have been described for particular lesions, particular histologies. One example is the Kaddish staging system for olfactory neuroblastoma, which is probably the most popular for this specific histology. So yes, there are staging systems that are being used, and they are of great utility, and a lot of those can accurately predict patient survival. However, we're not exactly where we need to be, and this is because again of the variation, the number of different histologies that are found in this area, and most of those histologies do not behave in the same fashion.
So once you've made your diagnosis and you've gotten your imaging, and as you write in this edition, the April 2017 edition of Clinics of Otolaryngology, you write that these tumors are often more extensive than they appear to be on physical examination. We're now looking at what type of resection we can offer. And I know that there's a great push for endonasal, endoscopic resection of these tumors, as opposed to the sort of large transfacial flaps that we used to do routinely back in the day. So can you describe to me how you can do an endoscopic approach for a malignancy in the paranasal sinuses or the skull base, keeping the oncologic principles of removing all the tumor with a margin?
It used to be believed that by removing these tumors with an open transfacial or craniofacial resection would allow us the best resection and the best outcome in those patients. However, it has been shown that this is not necessarily true. It seems like the fashion in which you remove the tumor is not as important as whether or not you can resect all the tumor. What has been shown recently is that in select cases, the endoscopic resection is safe, it's effective, and it's less invasive, and you can preserve more of the normal sinonasal architecture and preserve a lot of the patient's function, as opposed to doing the larger transfacial and craniofacial approaches. The way to really think about it is that when you're using an endoscope, even though there may not be a very large incision made, when you get to your target where the tumor is, you can see better. So you're starting at a very small opening, but your target to do your surgery and resect, you usually can see better than with the open approach, and that allows you to really tailor the resection that you're doing to the actual lesion. So it's more precise. In the proper hands with the proper training, you could probably do a better resection. But again, it all depends on the actual lesions. Even though in more advanced skull-based centers, we've been favoring doing those endoscopically with good result. It takes a significant amount of experience to be able to achieve the proper outcome. But again, it has to do with getting the proper visualization and exposure with the endoscope, which again at the target, which is where the lesion is. In a patient with the proper histology and proper lesion, if you select carefully, you can probably do better than with the open approach overall.
I would say, having read this, that the third article, looking at anatomic considerations, is really vitally important, because it seems to me that the surgeon approaching these tumors has to really be comfortable knowing the tumor approach three-dimensionally, knowing what can be preserved, what might be hurt with either the endoscopic or the open approaches. And I would venture to say that someone like you and the other authors in this clinics have really spent a great deal of time knowing the anatomy inside and out, from the cadaveric dissections and from imaging and from, in fact, looking at normals with the endoscope. Would that be something that the student needs to really, or our readers really need to pay attention to?
I would agree 100%. One thing that I remember one of my mentors told me is that nothing really beats knowledge of the anatomy and understanding your way in whatever surgery you're doing. And for sinonasal cancers, being in a lab finding out what to do in a cadaveric model, learning the proper techniques and the proper boundaries of the sinonasal cavity is really crucial in being able to resect those lesions safely with the proper margin.
I just want to take a quick pause here to let our listeners know that they can receive an exclusive discount on the issue we're discussing today by visiting us.elsevierhealth.com/expert.
So when you are looking at a patient and you prefer, as we all might, the less invasive endoscopic approach, but you realize that this patient needs an open approach, a transfacial or craniofacial approach. How do you do it, and how do you assemble your team to get the maximum tumor benefit in terms of full extirpation and the margins that you can get, while maintaining as much normal vascular and neural anatomy as possible, and maintaining as normal looking of a face as possible?
So one of the things that we looked at, we usually look at is how do we prevent ourselves from hurting a patient? Even though those endoscopic approaches seems to have less morbidity associated with them and is usually preferred, in some cases there are some specific things that you could see that may gear you toward not doing a tumor, resecting the tumor endoscopically. One of those is the encasement of the lesion, for example, encasement of the carotid artery by a lesion. It's very difficult to repair a damaged carotid artery if you're doing it the resection endoscopically. So this is something that we typically take into consideration. If there's a significant involvement of the brain parenchyma, meaning that the lesion there's a large amount of tumor inside the intracranial cavity, that's something that we'll take into consideration. And that may be a tumor that's better resected by the open approach.
So I know in this edition of Otolaryngologic Clinics in April of 2017, you also have really nice articles on very difficult to access places, including tumors in the clivus and tumors in my particular favorite anatomical spot, which is the pterygopalatine fossa or the infratemporal fossa. I think what I found interesting in the PPF article was that when this is approached endoscopically, it's really important to use a 0-degree scope and straight instrumentation, which I might have been misleading myself by using angled scopes. And I think that the ability to effect full tumor resection from those really difficult to access places using endoscopes in a more straightforward fashion is very interesting to me. I think as we move from surgery on to adjuvant therapy, can you talk a bit about radiation, either for primary treatment or for adjuvant treatment or even for palliation in these tumors?
Yes. So one of the main treatment modalities for these lesions is radiation therapy. And depending, again, on the kind of histology that you have or the size of the tumor, you may decide with a tumor board recommendation to go ahead with radiation first, or to give radiation as part of a combined therapy, or you could use it as palliation. Now, typically, the way we would make those decisions is based on the histology of the lesions. For the overwhelming majority of cases that require surgery, I'd say using radiation after surgery seems to be what's used most commonly. In some instances, if you feel as though a tumor is too big to remove with surgery, you can decide to treat this tumor with radiation therapy first, and that causes significant reduction in the volume of the tumor, which would allow your surgery to be easier. An example would be a tumor like an olfactory neuroblastoma, where there's been significant research done that's shown improvement when you reduce the tumor burden before you do the resection. However, in some cases, in a lot of cases, if the tumor is small enough that you can resect it purely, you can get the appropriate resection. In those cases, giving radiation afterward is also an appropriate treatment method. Using radiation therapy as a palliation is something that's been written about and that has been shown to be helpful in also reducing tumor burden in a lot of patients. So radiation, I would say, has a major role in management of these tumors for multiple reasons. But the way you would arrive at, I feel as though, at the proper way to use radiation is to always try to use a multidisciplinary type approach, present the patient in a tumor board setting, and get every single specialty is recommendation, and use that to arrive at the best treatment for your patient.
And I would say that similarly, when I read the article on chemotherapy, again, this is really based on tumor type. We had said earlier that there are over 40 different types of tumors that can be malignant in this area. So I would say that even the use of chemotherapy would be, again, very targeted and very much based on the tumor board deliberations.
That would be correct. Now, one thing with chemotherapy for these malignancies, even though there is some benefits to them, one issue that we have is that we still don't have enough research out there. There's no randomized trials that can tell us exactly which patients can clearly benefit from chemotherapy, but there are some data supporting the use of chemotherapy in certain situations.
I know that immunotherapy is gaining traction now as a much more targeted, individualized means of therapy. And I understand that it's in its I understand that it's in its infancy still. But it seems to me that there's an article in this edition that talks about using targeted immunotherapy for certain of these cancers. And again, I would venture this is something that the tumor board would discuss together.
Exactly. Now, I do believe that there will be more and more of a place in the future for targeted therapy for these malignancies. At this point, with I'll say the three main modalities that we're doing with surgery, radiation therapy, and chemotherapy, we're not doing as well as we should. And there's a lot of there could be a lot of advantage to using targeted therapy, because that would decrease the morbidity associated with the treatment that we're doing. The name targeted therapy means that we're actually gonna be able to focus on specific cells and on specific type of processes that would allow us to specifically target the tumor itself, as opposed to targeting other cells in the surrounding. Radiotherapy and chemotherapy, the way we treat this tumor seems to be in a non-specific type of fashion where we're causing trauma, not just to the tumor itself, but we are affecting healthy cells. So I think the advantage of targeted therapy is that it's going to be more specific to the actual lesion. And once we have the appropriate research and there's enough development, I expect that this is going to be a significant boost to how we treat these lesions.
So I want to thank you. This is Sujana Chandrasekhar. I've been speaking with Dr. Jean Anderson Eloy, one of the 3 guest editors of the April 2017 Otolaryngologic Clinics of North America on sinonasal and ventral skull-base malignancies. I want to congratulate you, Anderson, on putting together a number of articles and top-notch authors who have really looked at how you diagnose, different ways of operating, different other ways of treatment, and in fact how to reconstruct and how to set up a good specialized team to treat these complex malignancies. As a non-sinus surgeon, non-cancer surgeon, I found this clinics easy to read, and I really enjoyed the accompanying videos that I could access on the web. I want to thank you for putting this together. I wonder if you have a couple of sentences that will wrap up what you think this edition of the clinics can do for the reader.
So I think one of the most important aspects of this work is, as you mentioned, the group of experts that we were able to put together. I believe that one other very important aspect of this issue is that there is nothing in the literature now where you have all of these articles in one place. I think this is a very comprehensive issue that emphasizes just sinonasal malignancy and should be of use of a lot of significant help to everyone who's dealing with these complex and interesting lesions.
Thank you so much. Thanks for spending the time with me today.
It's a real pleasure.
Thank you for joining us for this edition of the Clinics Review Articles podcast. For an exclusive discount on the issue we discussed today, focusing on sinonasal and ventral skull-base malignancies, visit us.elsevierhealth.com/expert. Otolaryngologic Clinics is available for individual print subscription with accompanying online access, individual online-only access, as well as on the Elsevier electronic platforms Clinical Key and Science Direct. A CME program is also available. For more information on this series and our nearly 60 other titles spanning all medical disciplines, visit info.theclinics.com. Be sure to follow us on Twitter @ClinicsReviews and subscribe to the Clinics Review Articles podcast on iTunes and the Google Play Store.